will talk about the bone augmentation procedure in the treatment of anterior shoulder instability. I will focus mainly on latarga procedure and iliac crest grafting for revision cases. So as Ghazi mentioned about the pattern of the glenohumeral instability, it's really demanding, and it's not easy to sometimes diagnose the patient and give the option and give the treatment indication, because it's patient specific, and there are a lot of variants like etiology, direction, age, activity expectations, and bone loss. As we know, the most common complication after surgical treatment is the recurrence. It's between 0 and 50 in the literature. And the main risk factor seems to be the bone loss. And Burkhardt and Joe De Beer described the bone loss as an inverted pear-shaped glenoid. And if we have this bone loss, and mainly it's combined with the heel sacks, and if we do an arthroscopic Bankart repair, the soft tissue procedure, we will have a more than 60% of the recurrence after this procedure. And Itoye was described the glenoid bone loss limit in this cadaveric study in 2000. And this limit, at that time, it showed that it's about 21%. But we know that in these days, in recent studies, the critical limit of glenoid bone loss is becoming now 15. And as Ghazi mentioned about it, it's now about 13%. So if we have a bone loss lower than 15, we can go for the soft tissue procedure. But if we have more than 15% of bone loss in glenoid, we will choose the bone block surgeries. In my practice, I use this instability severity index score, which was described by Pascal Boileau. It is very practical, and when you decide to do something, you need to consider the age, the sportive activity, hyperlaxity, and the bone loss of the patient. And if you have lower than 3 of score, you can go for the soft tissue. If you will have a more than 3, you have to choose Hixas remplissage or latarga procedure or other bone block surgeries. You can use also the glenoid tract, but in my practice, I don't use it. But it's really good for giving the indication for these procedures. I mainly use for the bone loss, the bone block latarga procedures. If I have more than 3 in terms of IC score, and if I have combined bone loss, I go for the latarga. As you know, the latarga procedure was described by French surgeon Michel Latarga and was modified by Didier Pat. And this latarga procedure has triple block effect, 3B effect. It has the bumper effect, the bony effect, and the belt effect of the conjoint tendon. This conjoint tendon gives the sling effect, and it's really important, like the bony effect of the latarga procedure. This is the very good study and long-term with the long-term results, which was done by Gilles Walsh. Mean follow-up is 20 years, and as you see, the function scores and the recurrence rate are very good. But when we look for the postoperative osteoarthritis, it's a little bit high. This is a radiologic osteoarthritis. It doesn't have any effect on the physical examination of the patient. And when we look for the complication of the latarga procedure, the total complication is 25%. It seems high. It's mainly the recurrence and the infection, and the 10% of this complication can be neurologic, but hopefully the 2% of these neurologic complications were permanent. The arthroscopic latargia was described by Laurent Lafosse in 2007, and it was modified by Pascal Boileau as a Bristow latargia, and he used at that time the one screw, not like classic latargia. But after that, in 2016, it's become another technique by Pascal Boileau, and he used now the endo button technique and gives good results, good satisfactory results with his new technique. And Markus Scheibel from Germany was described also the iliac crest bone transfer arthroscopically for primary cases, and he also showed good radiologic results and functional results in his study. In America, the USA, they can use allograft frequently. In our country, we cannot use, and we cannot find easily the allograft options. And especially Tony Romeo and Matthew Provencher from Chicago, they use distal tibial allograft and give satisfactory results with the tibial allograft, but I don't have any experience about the allografts. So in preoperative evaluation, I always check the apprehension test, especially in the mid-range apprehension, because it shows me the glenoid bone loss. And in the CT scan, I always want a en-face view of the glenoid to be sure that to measure the glenoid bone loss, as you see in the right-hand side. We can do the latargia procedures open. It's very effective, and when we start to do this procedure, we always have to start with the open one to be able to make this procedure. In arthroscopic one, I started to do 10 years ago, and it's a little bit demanding and a long learning curve. And it has some steps like an open one. This is an example of my one of my cases. It is 31 years of age, the male patient. The IC score is 5. We can see the bipolar bone loss and the hyperlaxity. And also we can check the rotator cuff, and there's a partial tear of the pasta lesion in rotator cuff. I can go a little bit fast. You can see the anterior bone loss, and this is the cuff tear. And we dissect the coracoid process. We detach the pec minor, and we prepare the coracoid before the osteotomy. Then we do our osteotomy. Then we use the guide system, and we decorticate the bone, the undersurface. Then we put it flash on the towards the glenoid, and we screw in, and we check the stability and the if it is flash or not. And then we did a cuff repair in the same session. So it gives you an advantage to see the associated lesion and then check the graft inside the sitting and the position of the graft. But we sometimes have some complication like that. After 1 year, we can see some graft lysis, graft total lysis. As you see, this is the second look arthroscopy. There's nothing left. just the capsula, neocapsula, and there's no bone inside. So we remove the screws, and we use for the revision the adenine procedure. We take an iliac crest graft and put it for the revision, as you see in the CT scan. So why arthroscopic lethargy? Because we can do the arthroscopic examination of the shoulder. We can go for the additional lesion. We can treat the additional lesions. The graft positioning, we can check it intraarticularly. The post-op rehabilitation, early rehabilitation is possible. And the pain and cosmetic can be better. But for the graft osteolysis or osteoarthritis, we don't know. It's like an open surgery. We need to see some new comparative studies about it. So in 2020, we did a study about it. We check our results and we compare the arthroscopic and open one. And in terms of WOSI score, arthroscopic one was better. But interestingly, internal rotation loss is evident in the open one, arthroscopic one, and the alpha angle is better in the open surgery, and there's no statistically significant difference between two groups in terms of graft resorption. So open and arthroscopic lethargy techniques provide similar clinical and radiologic outcomes in our study. So this is my last slide. So this is my algorithm for the bone block surgery. If my patient has multiple dislocation episodes, either dislocation history, like during sleeping, undressing. So if the glenoid bone loss is more than 15% combined with the Hill-Sachs, and if the patient has some bad quality capsulolabral tissue during the diagnostic arthroscopy, and if my patient has the failed Bankart surgery, I go bone block surgery, and my first choice is lethargy procedure. But in revision cases for the lethargy procedure, failure of the lethargy procedure, I go for the adenine iliac crest procedure. Thank you very much for your attention.